A very good afternoon, fellow colleagues and friends. Um, Due to this COVID-19, I'm impressed that everyone has put up some webinars. When Dr. Odetta invited me to share my experience with immediate implant and immediate provisionalization, I thought to myself, oh my gosh, this is a topic. It's my favorite topic. But I also know that this is one of the most controversial topic that either the experts love it or hate it. Throughout my last 13 years in private practice, I can say that I'm still learning on immediate implants and immediate provisionalization. So I'll share with you today the journey that I went through the last 13 years with immediate implants and immediate provisionalization. In a short form here, throughout my presentation, I'll be calling it IIPP. My journey that I went through, this love-hate relationship, its evolution through time. As this is the webinar, I can't ask anyone to answer any questions, but just to think back and guess which year did IIPP first came to light in the scientific world. And in actual fact, it was in the year where Google Beta was first introduced to the world. It was also the same year that Frank Sinatra passed away and left us. It was also the same year that iMac, the most revolutionary computer, was introduced to the world. It was also the same year where the euro was accepted by the European Council. That year was 1998. That is more than 20 years ago. And a lot of people still feel that immediate provisionalization is not something, it's not scientific because it's so new. What were the 6 milestones of IIPP? And to me, when I look back throughout the years and throughout the articles starting from 1998, there were 6 major milestones that made IIPP surface and became accepted by the community. In 1998, Peter Worley was the first to publish 14 case series on the protocols of IIPP. Then it took another 5 years before more publications come on, which was in 2003, where Kahn and Grossman actually published significant articles that came out in the scientific world where people started to pay attention to IIPP. In 2005, Kahn introduced connective tissue graft, enhancing peri-implant tissue and thickness and stability because they were seeing data starting from 1998 as Peter Worley and Professor Joseph Kahn was also from Loma Linda. Then in 2008, that's where the rest of the world and different parts of the world started looking at IIPP and collecting data, and Dirouk published a review article where there was only actually 11 articles found to be valid out of the 43 articles, and they did find that we had to be cautious of the mid-facial recession. And Dirouk again in 2009 stepped up and said that it is essential to optimize aesthetic treatment outcome, and the word essential was what drove me to continue IIPP despite the publications. Then it took from 1998 all the way to 2014 before it was really accepted by the public as well as dentists around the world that this is one of the methods and this is one of the techniques that can be used to produce excellent short-term results, possibly because we do not have long-term data at that period of time. And also the first 5-year publication was out in 2014, and evaluation also showed that it has similar results to healed or sockets. People were not expecting a lot out of IIPP. And when we look back, how did this change affected us in our practice in implant dentistry? So for some reason, these 6 milestones of IIP, which is actually different from IIPP because immediate implant placement was not advocated even in the 1998s. And in those days, we were looking at single tooth immediate implant, and not many articles were out there supporting that. Thus, immediate implant placement into the extraction socket for single tooth, especially in the anterior zone, was only published without provisionalization even at that period of time, was first published in 2004. And that was by the group by Chen and all in ITI. The survival rate at that time was from 89 to 100%. So it was not as favorable as what we would call in healed sites. Then in 2009, Dawson and Chen also classified this kind of procedure as a complex procedure and is not safe for most dentists to do this. And the systematic review that came out in that same year said that there was a potential risk for recession up to 30% for IIP. That is a very high percentage range. And thus, if you place 100 implants, 30 implants are going to end up with recession. That's not a good number to start with. And so that was in 2009. Then in 2012, the systematic review further enhanced and actually emphasized that it does not support IIP, which means single tooth implant, immediate implant placement in single tooth concept. Finally, in 2014, something changed. And that was the year where I felt a little bit of relief because I started placing immediate implants or IIPPs from 2007 in private practice. And it was like what you say, a love-hate relationship. And being a specialist, we are all known to do what is scientific and what is safe. So what happened in 2014? The first ITI consensus statement came about to say that IIP, you have to have strict case selection with 5 keys. And that also in 2016, it also shows that grafting reduces horizontal bone loss and as well as buccal bone resorption. And that was a key article. That is only 4 years ago, if we think about it. Thus, it's not that long ago that IIPP is generally well accepted. In 2017, Levine published 10 keys for successful aesthetic zone single immediate implants, and that was also a key article that pushed IIPP into the front fork. So I love this quote by John Kennedy because peace is a daily, a weekly, a monthly process, gradually changing opinions, slowly eroding old barriers, quietly building new structures. And that was what we were doing and trying to do the last 10, 12, 15, 20 years, trying to prove that IIPP does work and that it allows good aesthetics and good function as well as benefits the patients. So the summary for today's lecture is actually, I was going to share the history of IIPP, which we have gone through now. Then the next part of the lecture is to discuss why there was so much controversy in terms of timing of placements, the risk, the pros and cons of IIPP, and also towards the end, the second last half of the lecture was I'm going to share what we view as the criteria for success for IIPP and what are the key factors. So my humble journey started, as I mentioned earlier, in 2002, in actual fact. In 2002, one of the faculties, one of our mentors, came to Australia at that time and showed me a slide. And that slide changed my life, literally, because in those days, in 2002, he was still using the conventional film slide. And thus, we were at a hotel and he pulled out his carousel, pulled out this slide and said, if you want to know, and if you need to know, and if you want to see what is possible, look at this. And when I looked at that slide, I said, impossible. Impossible because we were doing implants. I was working in a practice with implant placement, and my bosses were all placing implants, and we see the results. Unfortunately, when we look at the results, it's never the same, but it's good enough for patients. And when I saw that slide, it looked so real. You don't see the implants. The gums were back to natural state. I said, that's impossible. That drew me halfway across the globe to Loma Linda to learn what this is where we practice now. A tooth of number 2, which is number 10, we can see that there is infection going up in that gingival area because of root canal treatment and failure and fracture. Eventually, we extracted that tooth. and place the implant. And obviously, in 3 days, patients come back looking as if nothing has ever happened. This is what we do. This is what we hope we do for all our patients in our private practice. Thus, those training in those years were actually very beneficial, and it also allowed me to see two sides of the world. Because when I was in Loma Linda, I first started with the implant dentistry department. And with the implant dentistry department, the philosophies and the beliefs were so different compared to when I really wanted to do perio. I was on two ends of the earth where philosophies and principles don't agree with each other. But in order to make man whole, which is our philosophy in Loma Linda, we all have to come to a compromise and decide what is best for the patient. So when I came back in 2007 in private practice, I was weighing between the safety and risk that I was taking in doing certain procedures in our private practice. And I didn't have in the university at that time backup where you could push the envelopes and risk will be handled easily. So out in private practice, I had to decide what was unscientific and what was risky and find that balance. And I'm glad that throughout the last 13 years, that was the balance that we found. So let's look back at the publications on the timing of placement, which is important. In 2003, that was the first group that really stood out and said that the timing of placement of implant is extremely important, and you do need to define the terminology. The whole world have publications of all kinds, and if we do not define the terminology of timing of implant placement, immediate implants can mean multiple range of scenarios. Thus, they were the first to come out with that terminology. And of course, they proposed classification of 4 categories. And 2008, they added descriptive terminology for clarity's sake. And finally, just 4 years ago, they reviewed the terminology and documentation of the risk factors were definitely placed inside, and recommendation for different implant placement protocols post-extraction was also done. So thus, the definition of selection criteria for various tube options was finally defined clearly, and it took us quite many years to come to this conclusion. The timing of placement classification, why is it important to IIPP? Well, there is 4 types of scenarios as we know, type 1, type 2, type 3, type 4. And if we look at type 1, is where IIPP sits, or IIP sits where immediate implant placement is done following tooth extraction as part of the same surgical procedure. And thus is on the same day as extraction. And whether there was provisionalization or not, that determines whether it's IIPP or IIP. So there is still 2 sub-classification in type 1. Then when we look at type 2, early implant placement, we can see that is 4 to 8 weeks after extraction with soft tissue healing. Early implant placement is 12 to 16 weeks, which is 3 to 4 months with partial bone healing. And of course, more than 6 months is complete bone healing in type 4 situation. So when we look at publications of risk and start examining all the articles, we do need to be able to decipher the type 1 to the type 4 and what is possible and what's not possible. So in 2008, it was mentioned that recession of the facial mucosa was a common observation with IIP, and it was up to 30%, like I mentioned. And they highly advocated early implant placement because it reported a lower risk of mucosa recession. And a higher risk of failure was also documented in that same year, that with IIP or early placements is just high risk because there's not enough articles or not enough publications to support this kind of procedure. In 2013, that's when things really got blown up, where 13 out of 171 papers were selected. Advanced mid-facial recession was documented in 64% of the cases. 64 is a very high number if you're practicing in private practice. And remember, I started in 2002 and 2007, and to see 64% of cases failing, that would not be a good day. at all. So only one of these studies demonstrated high risk of more than 10%, which could be the cause because they did identify that maybe there was no immediate implant crown. That may have been the reason. And immediate implant crown seems to be pivotal given the results of a randomized controlled trial. So at that time, IIPP demonstrated limited risk for advanced mid-facial recession of less than 10%. And that was people could not remember the good part of the conclusion, but everybody remembered that it was 64% of mid-facial recession. So in 2014, again, Chen and al. Published the outcome of 50 studies where they examined, and they found that there was higher frequency of mucosal recession of more than 1 millimeter. Thus, strict criteria was developed for IIPP, naming that type 1 is not a procedure that should be done easily. So when I really looked into these two articles, the 2013 and the 2016 by Kozin and Chen, it is important to look at what was being published or what was being examined. And when we look at this table 3, which is a lot because we went through so many articles, I was just focused on the mid-facial recession. And if we look down the line, you can actually see that the recession were ranging from 0.5, 0.2, 0.3 to 1.13 millimeters. As it continues with the table, it is still at 1.16 millimeter at the maximum. And it's the 1.16 millimeter, when we look at the Rook article in 2009, you could see that it was happening at the submerged immediate implant, which is the type 1 without the provisional crowns. Whereas when there was provisional crowns, it was 0.4 millimeters of recession. Thus, do we classify this as advanced recession? There is no way of really answering that question. And when I look at the 2014 article in Chen's, where you can actually see the timing placement or placement timing of implants in type 1, you can see in the mean mucosal loss or recession type, the articles were ranging between 0.1 millimeter loss and 1 millimeter gain. You can actually even end up with a gain with type 1, but you can't end up with a gain in type 2 most of the time. So that kind of kept me quiet, and despite us lecturing and people saying that we were doing a high-risk procedure, I still plow on because there is a chance of us gaining 1 millimeter gain. Then thus, but what really hit me in 2016 was this article, and this is a very important article because it's one of the first few 5-year prospective case studies where they collected patients in a private practice, which is relevant to us because in the university setting is always different compared to private practice. And this 5-year prospective study, there were 22 healthy patients that were being selected. And mind you, they were selected over 15 months, which means IIPP, to get patients with an ideal profile is not an everyday thing that you will practice in your private practice. You actually will, it's luck when it comes along, and once a month, you'll be very, very lucky to be practicing that. Thus, 22 healthy patients, if we see them, and they were highly selected where they were ideal candidates for IIPP, and cases demonstrating major alveolar process change or advanced mid-facial recession of more than 1 millimeter were treated with additional connective tissue graft within 3 months after the implant placement, which means they were even intervening after placement of implants. And the permanent crowns were restored at 6 months. And out of those 22, 17 followed up, and 8 out of the 17 showed aesthetic complications. So there was high survival rate, but mid-facial recession was deteriorating after 1 year. And with this high aesthetic complication rate of 8 out of 17 in well-selected patients who had been treated by experienced clinicians, type 1 placement may not be recommended for daily practice. That's why I say that when I was lecturing IIPP over the years, I have my doubts, and sometimes I don't like to talk about it because scientific articles sometimes shows different sides of things. But when I really look at this article and look at the recession amount, again, it was 0.53. Thus, it was a very, very small number, but it was blown up in the way we write and read the text. The last, in 2019, again, there was publications that show that the soft tissue recession and patient-reported outcomes were underreported in many case series or publications. Thus, the lower implant survival rate of IIP versus delayed implant placement was not a very favorable thing for us to do type 1 or type 2 placement. All right. Of course, they did say that we need more randomized controlled studies, but nonetheless, this is what it is now with scientific articles when it comes to risk. So in our practice, we have been doing this for years where we know that a situation of the 2-2 again allows us to encourage more placement, immediate placement of implant, encourage even aesthetic reconstructions of the anterior teeth. And the most recent case that I have, which we have not restored, was this 2-1, the tooth 2-1 of this patient, where we could actually see positive growth of gingiva. And the crowns were tested. We realized the crowns were, aesthetics were not as good. It was being sent back and a temporary was being placed back on. So this is what we hope for in immediate implant placement the most in private practice, where you actually gain soft tissue. Thus, how did we practice the last 13 years? Well, in 2006, before most of these articles came out, we had our own analysis of options. And true enough, it was still when a patient walks in, when you have a tooth that needs to be extracted in the anterior tooth, you need to decide what are the options available for the patients. And again, it was 1, 2, 3, 4. Of course, we name it differently. But when we look at the pros and cons that we start examining, I can see that IIPP actually ends up with more pros, and of course is how you write it. And then the cons obviously is increased risk. However, the cons of delayed implant placement is far more than the pros as well. So when we look at this ourselves, then in comparison, when the articles came out with the scientific way of documentation and writing, we could see that the advantages and the disadvantages were not far off from what we analyzed previously. And without going into details, because every single point can be picked up and we can have a whole day lecture on it, we can see that type 1, we have 3 advantages. Type 2, we have 2 advantages. Type 1 and 2, they both have 5 disadvantages. How do we weigh this? But if I were to weigh this, and if I were to take a bet, obviously between type 1 and type 2, I would still go for type 1 where situation allows. So what is that analogy that I explain to fellow colleagues sometimes? The analogy is like a car and a tooth for a patient. It is very technical, this technique. It is complex, it is high risk. However, it depends on the driver, it depends on the surgeon. And whether you want to take that kind of risk is really dependent on the driver as well as the surgeon. The skill as well as the risk appetite is important as well. What made us pushed on with IIPP was this article in 2003, where although there was 0.5 millimeter of recession that was noted after a year, we realized that all patients were very satisfied with the aesthetic outcome of IIPP, and none had even noticed any changes in the gingival level despite the 0.5 millimeter loss. Because true enough, 0.5 millimeter is really quite difficult for patients to see or even remember what they look like after 3 months or 6 months. The undeniable benefits of IIPP was the possibility of maintaining hard and soft tissue architecture and the possibility of enhancing gingival contours and proper architecture, as well as patients, because patients love it due to the fact that it improves their comfort and quality of life. So what are the published advantages? Well, there were quite a lot. And yes, advantages in that sense, if we look at the scientific risk publications, it's not as scientific because it's difficult to measure what you lose and what you gain in that smaller 1 millimeter of compartment. Thus, in 2009, we did see by Giroux that the mid-facial recession was 0.75 millimeter more in delayed restoration. And there was improved patient comfort. And in 2009 to 2014, a lot of systematic reviews advised clinicians that it showed an excellent short-term outcome. However, we are not sure how it would look like in 10 years, 15 years, 20 years down the track. So yes, it is presumed to be a reliable treatment. Nonetheless, we have to be cautious of what we are doing. In 2014, we identified, as Morton has published as well as Kenyaya, that thick IIPP needs to be placed in thick biotype because they end up with less mid-facial recession and better papillary height, which a lot of publications have shown better papillary height, but it has never been highlighted in many articles due to the fact of recession overtaking the gain of papillary height. So then, over the years, Stephen Chu and the group also published that with the effect of bone grafting, provisionals, as well as soft tissue grafting, there is a net gain in soft tissue height and thickness about 1 millimeter. And the increase in vertical and horizontal dimensions for grafted sites were between 0.5 to 1 millimeter, as compared to sites with no bone graft and no provisional restorations. So there is a gain, there is a loss, and the numbers are all about the same. Thus, when we look at the latest publication, and this just came out last month, we can see that 1-year prospective study of 100 consecutive patients for IIPP, which is a huge number to collect, that the PES as well as the WES, which is pink aesthetic and white aesthetic scores, that were used, which it shows that first year post-surgery, the numbers were raised, and it was raised to almost excellent if you add them together, close to 20. The mean PES scores for mesial, distal, papilla, soft tissue marginal levels, contour, color were raised significantly. So it's not just mid-facial recession, it was everything else around the gums on the tooth. So that conclusion came out with following IIPP, a high aesthetic outcome was achieved. Thus, this is a good month and this is a good time for us to be talking about IIPP. Now, the benefits of IIPP, as you have seen with all the articles beforehand, are very scientific, very technical, and none of it really talks about patients. Why? I don't know. All these years, it's just because we are dentists, we are scientists, we tend to look at things in millimeters, and we don't look at things, or even in 0.1 millimeters. We don't look at things from a patient's perspective. It was only in 2018, which is 2 years ago, ITI consensus report says that patient-reported outcome measures should be gathered in every clinical study in which the outcomes of oral rehabilitation with dental implants are investigated. And that is an excellent point, because what we view as success or failure is not what the patients view as success and failure. In the same case as IIPP, when I look through my patients over the last 13 years in private practice, they all give me these reasons. The reasons are less surgery, less cost, shorter treatment time, less visits, tooth back instantly, and I don't need a denture or temporary. Those 5 factors are enough for me to take the risk. So my humble journey of pushing the envelope started 10, 15 years ago. It's not today's lecture to show you how we push the envelopes, but we can see that throughout the years, we actually gain more than we lose. So coming back to when was the first success criteria that was being published scientifically was actually in 2014. 2014 was the year where everything changed for IIPP, as I've mentioned quite a few times now. And Morton and all was the first to say that if you have 5 keys for an ideal host, you end up with a thick tissue, soft tissue biotype. You have bone apical and palatal, you have intact socket walls, you have no acute infection, you have facial bone wall at least 1 millimeter thick, you can proceed to do IIPP. I can tell you that this ideal host does not exist most of the time, but it is definitely one of the most important criteria and strict criteria that's necessary for us to perform predictable IIPP. The next one that came about was actually in 2017, which is only 3 years ago, and there were 10 keys being published by Levine. Then in 2018, 2 years ago, there were 13 factors that were being published in Khan's article. Thus, over these last years, you can imagine for this procedure to be successful, you need to control many factors. Why was it so long? It took so long because if we looked at the first slide that I showed earlier, case series started publication from 1998 all the way to probably about 2005, and it's already 5 years by that time. Then clinical studies started. It took another 11 years before systematic reviews could really come out and examine this technique. Thus, when we look at this criteria, success criteria for IIPP, we can see that this 5 keys, 10 keys, and 13 checklists are actually important. And when I look at the whole list throughout the years that we've been practicing, they are all important, but the total factors are 28. I attended a lecture last year on IIPP when I was in Chicago. It was kind of funny because when the lecturer went up and said IIPP is the best thing on earth, and in order for you to be successful, you need to follow these 13 criteria and 13 points. When it came to point number 3, I'm quite sure like you guys now, if I tell you that 28 points, you're probably all going to faint. And that is exactly what happened to me. So, but there are key criteria, key success criteria, and how do we simplify it? In order to simplify it, in actual fact, out of all the criteria, there are 3 key factors. The 3 key factors are patient, surgeon, and the implant site, which is what we have been advocating all these years. But when we look at these 3 key factors and how scientifically it was being identified, you can see that out of these 3, there was only one out of the 28 factors, there was only one factor that was being published for the patient. Then there was at least another 10, 11 factors in the surgeon, and then another 14 factors in the site. And this is after we actually decided to take out the overlap factors. So when we take out the overlap factors, there was only 26 factors that we have to look at. Is this good or bad? Well, for IIPP, it means that low expectation patients experience a meticulous surgeon. Ideal implant site with no infection is absolutely necessary in order for IIPP to be successful. So how do we look at these 28 factors or 26 factors? I can easily add another 10 factors up for IIPP to be successful. But what are the true critical factors in order for IIPP to be successful, and how many of them are critical? So let's look at this. When we look at the 26 factors after minusing the repeats, the red factors are the ones that we have identified as 8 critical factors when we have to have before we start IIPP. Thus, I'm going to use a case to illustrate these 8 factors. What are these 8 factors? Aesthetic risk assessment, that is absolutely necessary. For all our patients, we tend to talk to our patients a lot. You need to explain to the patient the options available, the techniques of options available, what the risks and the pros are, and thus, if the patient has high smile line and multiple reasons and very specific about aesthetics, where they can even identify and tell you that this gum is a bit higher than the other gum line, well, those are not exactly the kind of ideal patients you want to start with. Then with the surgeon, obviously, the factors have always been mentioned by multiple parties is 3D implant placement along palatal wall, the buccal bony gap that has to be filled with bone graft, which was highly debatable over a period of about 3 to 5 years. During that period of time where the community was saying that there was jumping distance, you don't need to bone graft. Then there was, nonetheless, in IIPP, we have always bone grafted regardless of the gap size. Then with the third factor is immediate contour management of emergence profile, which I will describe in a case later, as well as primary implant stability. Well, the other three factors that are really critical of the site, it was not all five factors in Morton's key. It was actually availability of bone apical and palatal of the site, as well as the facial osseous gingival tissue that has to be measured, and then the bone sounding of adjacent teeth. And the facial osseous gingival tissue includes the gingival biotype. So when we look at these factors, if we can see a case like this, which is very common, which a patient can walk in, it's a 70-year-old, fractured 1-1, he can't stand wearing a denture. He says he's been walking around without a tooth for the last 3 weeks. I've got no relevant medical history. You know that is hallelujah. It's a good day because patient has no aesthetic risk concern. He was walking without a tooth for 3 weeks. And I mean, look at the restorations that he has on his anterior teeth. They are not ideal at all. And he says that I'm fine as long as not causing more delays. They're just stains. I was told by a dentist, I don't need to replace it. So these are the kind of patients we all hope to have. So the second factor is facial osseous gingival tissue. What do we mean by that? We actually do bone sounding in every single case. And the bone sounding is necessary to determine the dental gingival biological width that we all talk about. Thus, in this case, it was 3 mm, 2 mm mid-buccal, and 3 mm on the mesial. That tells us that there is bone on the buccal wall and there is intact socket wall all the way around. So the third thing that we look at is actually the availability of bone apical and palatal, because the apical bone and the palatal bone is going to help us anchor and secure the implant. If you don't have that, it is impossible for you to even do IIPP. With that, we have to mention these two articles that came about in 2011. They did identify and tested and looked through many CBCTs to realize that there was type 1, 2, 3 published in Lau's article, and in Khan's article there was a type 4. And when we look at this type 1, 2, 3, 4 situation, type 1 is obviously favorable, type 2, 2, type 3 and type 4 we have to be very, very careful, and type 4 you can't even do IIPP most of the time. So that was the situation that we look at, and thus we need to know that there are different anatomy for different case, even though it's a fractured tooth. The fourth point is actually bone sounding of adjacent teeth. The adjacent teeth bone actually determines where your gingival level is going to sit eventually. And this is hard to prove scientifically, but this was one of the main factors that was mentioned in Khan's article early on in 2003, although it was missed by many in that article, but is one of the key factors as to why we identify patients whether we do IIPP or not. In this situation, there's 3 millimeters, and we know that the bone on the adjacent tooth is intact, and thus it's a good day for us to do IIPP. Then upon extraction, we always double check the buccal plate to the gingival level again, even though we have done this in the first slide of the first factor where we were doing bone sounding. Why? Because upon extraction, sometimes we end up causing adhesions, or sometimes we end up pulling the buccal plate out ourselves or destroying the buccal plate. And sometimes we might not be probing properly during the bone sounding check at the earlier on situation. Thus, this is important to check that the bone is still intact and the bone is there, and that the biological complex is still the same from before. So when we look at this, once we look at that, then only it moves on to the surgeon factor, which is the 3D implant placement along the palatal wall. When we look at the 3D implant placement along the palatal wall, what we try to achieve is an osteotomy that is along the palatal wall, or depending on how the sagittal root positions are, we do shift in different positions depending on the type 1 to type 4 that you've seen earlier. But nonetheless, it is always along the palatal wall that we would like to have the implant to be positioned. And as you can see here, that's a BLX implant. And why an implant, although is not identified as one of the main factors, but it is also one of the key factors of IIPP's practice. If we use an implant that's not self-cutting or does not allow high torque value, it is sometimes difficult for the surgeon to get onto a 3D implant placement along a palatal wall, because most of the time when we extract a tooth, the wall or an intact socket wall is actually quite cortical and hard boned. And with hard bone, if you use an implant that is not self-cutting, it is easy to move out of position and it doesn't fall to where you want it originally to be, because when you're drilling, the drill cuts. But when you're placing the implant, if the implant doesn't cut in the same way, that's when your implant goes out of position. So this is where we want and hopefully want it to be. Even in that situation, I didn't get it perfect, but still it was acceptable. And of course, nowadays with 3D planning, it is so much easier. There are surgical guides that we can use. Guided surgery can be used. Nonetheless, I can tell you surgical guides, they do have its pros and cons. That's another discussion altogether. And sometimes we just can't feel with the surgical guide as to where you're drilling or whether there's engagement or what's going on with the drill. So this is where we want things to be. The surgeon actually plays an important part. The feel, the sensation when you place the implant tells you whether you are in the right position or in the wrong position. And there are many situations that can happen and many things that can fail despite what you plan for. Why? A situation like this often happens, in actual fact, in IIPP, because you want to be so palatal and you don't realize that there's not enough clearance up the apical area. You end up perforating on the apex, and this is one of the main reasons where IIPP fails. Second reason is also this, where the implants, you've prepared the site and you think you're doing a good job and you anchor the implant and you get a secure anchor because the implant is anchored on the apical area, but actually in actual fact you have destroyed the palatal bone. That is another one of the main factors that also causes failure in IIPP. So thus primary implant stability is very important, and having a good implant system that has a high torque value is important as well in order for you to be able to engage and ensure that you have good stability. The minimal torque value for immediate implant, people always ask me this question, and I tell them that if I'm going to do a provisionalization of an immediate tooth right on the implant, I would minimally want it to be at 35 Newton centimeters. But the higher the better. Well, nowadays with implants like the BLX, it's 18 Newton centimeter, which is fantastic because it goes up to a high level, but you do have to be careful how you use it as well. So that is the minimum if you want to put a crown on top. What happens if you don't end up with a 35? I can tell you sometimes we just can't place a provisional restoration. That is a lecture altogether. And we do something else for maintaining the space. Thus, the seventh factor is actually the buccal gap bone graft, which, as I mentioned earlier, some people say that there's no need for that, but for us, it is definitely a need, and there have been multiple studies now saying that there is a necessity to do that. You can even gain bone back. In compromised situations where there is not even buccal bone, you can actually grow the bone back due to the buccal bone grafting. Number 8, which is the last critical factor, is the immediate contour management of emergence profile. A lot of people look at this factor and immediately says that it is the contour of the crown. I would say that there is two ways or two parts to it. The two parts is actually, firstly, the gingival tissue emergence profile, which is the connective tissue. Why? Because we do need to get a piece of connective tissue that can help with the emergence profile. And this is what happened in this case. And my favorite zone is actually the tuberosity, because what we need is actually very little for a single tooth. And thus, with the tuberosity, it's easy to obtain. There's not much of healing impairment later on as well, and patients don't feel it very much. And thus, it was quick and easy segregate to obtain the connective tissue and remove the epithelium, and then attach the connective tissue to the buccal profile before we even place the temporary crown. And of course, the temporary crown, as we can see in this situation, is the immediate contour of the temporary crown, which I will show in the next slide. That is also important in ensuring that the profile maintains and that the tissue can maintain as well. Where the temporary crown sits, we all know that this temporary crown should be out of eccentric as well as a normal occlusion. And with the eccentric occlusion, sometimes we do have to shorten the crown to this level. Does patient worry about this? Most of the time when I explain to the patient, they say, I would rather have a short crown than have no crown, or to have a denture. And if you look at this temporary crown, you can see that you can't see the access hole, but actually the access hole is on the buccal. Thus, the access hole of the temporary on this temporary abutment was actually on the buccal, as you can see in this situation. And the emergence profile should always be concave and not convex. Why? Because firstly, we need to torque the temporary abutment to 15 Newton centimeters minimally to ensure that there's no movement that would prevent the healing of the contour of the gums around the emergence profile. Secondly, the contour is so important, and it's just in a quick short video here where we can see very often patients or dentists or sometimes technicians that don't understand, they like to contour it to match it or to the adjacent tooth or to close the gaps. They end up with a severe overhang, and you end up with lots of other issues. I have been very lucky from last year where when the temporary restoration abutments came out of the series from BLX, it was interesting to note that they actually taught this through very well. And you could see that there was actually 3 heights that were available for this temporary abutments. There was gingival height of 1.5, gingival height of 2.5, and gingival height of 3.5. Situation temporary abutments, that means different sizes of temporary abutments to allow you to help you to create that proper emergence profile, because every implant is placed in different scenario, and to put good temporary restorations, you need good abutments to start with. Most of the time, temporary abutments are given in one size because they feel that it's just a temporary tooth. You don't need it to be perfect, but actually you do. So as we can see, 10 days of no brushing in that area, patients come back healing quite well. And when we remove the temporary crown to take implant impression and scan, you can actually see the gingival healing nicely around the contours of the implant. Thus, that's the permanent crown, as we can see. From the buccal access hole, we are now able to move the access hole to the palatal due to the angled solutions that are available now. And the angled solutions have helped us so much with immediate implants restorations, permanent restorations for anterior teeth, because screw retain restorations is still our preferable choice. We prefer not to cement. In the earlier days when we didn't have this option, we obviously didn't have a choice but to cement crowns, right? So that's where the crown was being inserted on the day of insertion, and that's what it looks like. Patients, as you know, a 70-year-old, convincing him to change the rest of the restorations around just to give a good picture, he was not happy with what I was going to say. So this was the best that I could get down to. But he was extremely happy with having a tooth back again. That is what we see now with the palpal access and the gingival and papilla level that we have maintained. And this is what we do. And this is how we proceed. And that's on the day of the surgery, which we know that the papilla eventually, upon 1 year, would actually grow further down. These are the final x-rays. That was the x-ray with the temporary abutment, testing and sitting of the temporary abutment, ensuring that it is the right size and the right platform before we went on to the permanent. So in summary, IIPP can be superior to other options when all factors are controlled. There are three keys, and I told you there are 8 specific factors, but the 3 keys boils down to the patient factor, the surgeon factor, and the site factor. If we really want to look, there are more than 28 keys or factors. We have to look through a pile of 30, 40 factors before IIPP can be done consistently. But what I would like to share is that IIPP is not for every day. If you look at the study that I mentioned about risk of recession in 2016, Cosin's article, it took them 15 months to collect 22 cases of ideal host case. So in our practice, the last 13 years, you can imagine it's always a celebration when we get a case for IIPP because it has taken us so many years to document the cases and to be able to follow them up over the 5, 10, 13 years. The results are amazing, and we hope that we are able to share that as well eventually. So I love this quote by Joseph Albers. There is no difference between science and art when it comes to creativeness, productiveness, and to come to conclusions and to formulations. And I feel that IIPP is one of those techniques or armamentarium that has grown the last 20 years in implant dentistry. Thank you. I've got a last video to share, and it's just a quick video showing you how we do IIPP even in compromised cases as well. Thus, enjoy and thank you. I can see some questions. Am I supposed to just read them and answer them? And hi from California as well. Does type 1 or type 2 will be enhanced by soft tissue graft? We personally, I mean, from our studies coming out from Loma Linda, obviously it is a yes. Soft tissue graft does help to enhance the contour as well as maintaining the stability of the soft tissue. So the answer is a yes. However, in some situation where we place type 1, soft tissue graft is not advocated, especially when there is no buccal bone, because you do not want the soft tissue graft to grow into the bone graft that you have grafted. So there is a yes and there is a small no behind. And that's another lecture on compromised immediate implants on compromised sites altogether. Coming from Dr. Liu, what is your post-op care regimen or routine after IIPP? We normally tell patients that obviously it starts from before the surgery. They're given pre-op antibiotics and mouth rinse to start, and upon finishing the surgery, they are told not to brush that specific area. Every other area that are no surgical areas, you can continue to brush, just that area, no flossing and no brushing in that area. Use the chlorhexidine mouth rinse. And we normally see patients only 10 days later. Unless I'm very unsure, then I will see patients 5 days down the track. Most of the time is 10 days later. They don't need to brush that area, just with the mouth rinse and salt water as well to enhance healing. Then antibiotics for 5 days. Nowadays is usually augmentin, as well as painkiller. We use two analgesics, but most of the time my patients tell me that the second analgesics was actually not necessary. As you know, that pain needs to be controlled by two pathways. So we use a non-steroidal as well as a paracetamol. Yeah, so that's our usual regimen. Thank you. And the third question was, what was the cause for the reported gingival recession in the earlier reports? That's a very interesting question, and it actually, I was hesitating on putting so many articles in this lecture because it's only 1 hour. It would put people to sleep. When we really look into these articles, a lot of the systematic reviews, it's hard for them to measure. And in those days, they were not measuring gingival recession because it was not something that they were looking at. So there was a lot of heterogeneity among studies. Some studies, there's just no SOPs, basically. There's no standard operating protocols among the whole world of the scientific world trying to ensure that when studies are collected, reports are collected, results are collected, or the materials and designs are all the same. Unfortunately, it is not, as we know. And because it's not, you get different level of gingival recession reported. For example, let's not talk about different groups. Even in the same group, we in the same protocol coming up from the same group of publishers or researchers, we also see different results coming out. Why? In Khan's article in 2003, they measured and said that there was maybe 0.5 to millimeter of recession in that group where it's highly controlled. Then when he used connective tissue graft a few years later and published the other article, it was also it showed 1 millimeter or 0.5 millimeter of gain of soft tissue when you do connective tissue graft. But these two procedures are slightly different, even though they are IIPP. One has connective tissue graft, the other doesn't. But both studies were being picked up by the systematic reviews, saying that it was well designed, thus we're putting it in. But you can imagine immediately all the means get distorted. So every single article, and if we have to look through, seriously, there's a lot to study, and that's why there's 28 factors, and there's even more than 28 factors to consider when we want to look at the reported recession. But the good news is the reported recession is actually very minimal, 0.5 to 1 millimeter, and most of them are not more than 1 millimeter. And those that are more than 1 millimeter, majority of the cases of these reports are actually without provisional restoration. I hope I answered that question. In East Asia, bimaxillary proclination is very common. That's the next question. With proclination, there is usually very little or even no labial alveolar bone. In such population, IIPP may not be possible. And let me finish reading this. Only with grafting. May not be possible or possible only with grafting. It is possible, and it's actually one of my favorite topics in IIPP in compromised sites. Hopefully I can share this one day. I practice in Malaysia now, the private practice, and majority of our patients are Asians. And yes, there is a different set of profile. We don't get thick buccal bone. Patients don't show up when they first fracture their teeth. They will show up maybe 3 months, 6 months later when there's infection. So we did push the envelope, as you've seen earlier in some of my slides. But grafting helps, and grafting allows us to be able to regenerate bone out. And one of the key articles that published that I'm able to say that now was actually Sanajo. I think it was in 2017 when the article came out. I was very, very happy because that was proof, scientific proof, that you can grow bone with IIPP and help the patient out. All right. The next question, with your statement that, sorry, I'm just trying to read this. With your statement that the implant placement might perforate the palatal wall, If it is not guided properly, implants normally not self-threading, which would avoid that scenario from happen. Also true, yes, previously when I was not using a self-cutting implant, I don't tend to see that phenomenon of buccal bone disappearing from us. Um, However, without using the self-threading implants, it's hard to sometimes get a good engagement because the non-self-threading implants means you have to use the drill all the way to the end. With the self-threading implants, I actually am able to reduce drilling depending on how the bone feels and allow the implant to cut the bone as it goes in. So there's pros and cons in both ways, but both ways can be done successfully if you know how to control the implant and the surgical site. All right. I hope I answered that question. And you showed the slides of gingival graft from the tuberosity and you inserted the graft into the labor pocket created after extraction. This gingival graft is done together with filling in of the jumping gap after placement of the implant. Do I take it that for IIPP, you place both bone graft and soft tissue graft? Yes, the answer is yes, I do. With IIPP, we tend to place bone graft and soft tissue graft together when we can. If I have a choice, sometimes I don't do the soft tissue graft, I actually choose the bone graft. It's more important actually with the bone graft, as you have seen in the video. Unfortunately, the video was stopping due to the loading of the video just now. So there was no soft tissue graft in that case. All right. Thanks. Thank you. Thank you. Greetings from California. Thank you. Hi. I can't believe you guys are up early this in the morning. It's crazy for you guys. It's like your sleeping time in California. The next question is, one of the criteria for IIPP is that there should not be any infection. In the final video you showed, there was an area of lateral bone loss, probably due to infection. In such cases, do you just do curettage and insert the implant anyway? Well, one of the eight factors that I mentioned earlier was actually adjacent bone present, which is bone sounding on the adjacent side. That's a key factor, and I do have a diagram. I've come up with some three-dimensional diagrams that we have classified them into 1, 2, 3, where we feel that it is possible to place the implants even then there is no buccal bone when there is infection. Once the infection is removed, lots of time spent on curettage. When I was editing that video, and the person that was helping me edit the video, it was quite funny. It was asking me why is this part so long? You know, there was so much time spent on curetaging and cleaning up the socket, and that's absolutely necessary. And only with that and understanding the remaining bone that's available in the socket wall, even though there is 4 socket walls, if one of the socket wall is not present, the other 3 are present in full, as well as the apical socket wall, which we always talk about 4 socket walls. We don't talk about the apex. And the apex, that bit is actually the one that tells you whether you can or you can't place the implant. Yeah, so it's a hard question for me to answer in a Q&A. Yeah. Yeah. Oh, thank you, Steve. Thank you so much. It's another question from Dr. Raj. How many cases of anterior IIP do you end up using angulated abutment? That's a very good question. I would say most of the time, because if you look at the sagittal root positions of what have been published, you know that type 1 situation comprise about 80% of the population. So in type 1 situation, the bone is on the palatal, yes. However, you cannot go entirely palatal with implant placement and come out through the apex on the socket. And if you come out through the apex on the socket, there's no more IIPP. It's a gone case. It's a lose-lose situation where you just have to waste the implant, and I've done that before, where you open up the implant and go, oops, that's it. You know, we could then reverse the implant and do a socket preservation and start over again 3 months down the track. So So most of the time, I would say probably 60–70% of the time, I would end up with an angulated abutment. Thus, I'm very happy with the angulated abutment. We started using it maybe about 4–5 years ago. When it first came out, it was not even bought by any implant companies yet. That was one of the best solutions. And there are certain things about the angulated abutment designs that are not good prosthetically, but that's for another discussion. Yeah. Thank you, Steve, for the great lecture. And another question, does immediate implant with early loading get the same results from early placement with conventional loading? Well, immediate implant with early loading means, I guess you mean that you place the implant, but you don't place the crown on the same day, or you place the crown later on, if that's what I get your question to be. Well, I don't think people have really documented this kind of procedures where they place the implant immediately and they load it a few days later. The gums grow so fast, they heal so fast. As you can see in some of my cases, within 5 days, it looks like normal. So I mean, it's taking, in those days where we have to do a lot of uncoveries, and if the uncovery, the healing abutment falls off, you can tell if the patient doesn't come in a few hours, the gums would have collapsed in straight away. Thus, with immediate implants, my advice is to have the provisional restoration done straight away, because if you don't do that, the next day it's a bigger mess trying to put things in and trying to get the right contour to be managed or to manage it. All right. Any thoughts on incorporating socket shield technique with IIPP? Yes, it's a very difficult procedure that it really depends. To me, socket shield technique is really needed in situation where there is no adjacent bone, or you know that the adjacent tooth is an implant, let's say, because what we are trying to achieve with socket shield technique, which I myself don't practice, is done very much by my colleagues in Loma Linda, is to preserve that precious interdental papilla. And that precious interdental papilla is something that the whole world for the last 20–30 years, and that was how Peter Worley started, is because of this, trying to preserve the interdental papilla as well, with IIPP. Thus, if there is bone on the adjacent tooth, I don't think there is a need. It's a highly sensitive and difficult procedure, and you have to be trained well to be able to do that as well and spend a lot more time. And we have found that even without socket shield, we do get pretty good results, right? Yeah. And the next one is, may I clarify what's the purpose of using concave or negative emergence profile? That's a good question. The negative emergence profile is to ensure, remember there was a short video that I showed at the end. If you have a concave profile of gums pushing out to the gums, what you're creating is an overhang that allows food to get stuck underneath, and it allows the gum to shrink back, and you end up with more recession. Obviously, we want more gums to grow down, and not apically, we would like to grow coronally. We want the creeping attachment, or what we call in periodontal terms, which means we want the gums to creep back down as much as possible. And the more concave we have, well, not too concave, then it will sink in. That would allow the gums to actually flow in and actually reattach further down as well. So that's the purpose, all right, and ensuring that you get enough support to not allow the ridge collapse as well. Yeah. Thank you. I'm glad I answered some of the questions, and you're beginning to tell me that I answered it correctly, because I'm not sure whether I did it right. All right. Next question. All right. Thank you for the presentation. Thank you as well for listening. In case of infection, do you use any antibiotic inside the socket after curettage? Very good question from Greece. Thank you, Dr. Eugene. We do. That was not shown very well in the video. We do, and normally I just irrigate with the antibiotics as well, or I actually put some tetracycline on a cotton pallet with saline, and upon good curettage. It's still curetaging. It's manual job. The antibiotics is not going to kill off your granulation tissue. So it is only just going to kill off maybe some bacteria and clean up. In fact, to me, the antibiotics is to help me to be able to see better whether there is granulation tissue left behind. So it's the manual cleaning that is still necessary in infected sites. All right. Thank you for the presentation as well. How do you plan your immediate implant placement? Do you use guided stand during surgery? We do use guided stand, but at the beginning, previously 10 years ago, when we didn't have guided surgery so easily available, and in those days, guided surgery stents, surgical stents were so expensive, it was hard to justify every single case to use guided surgery. What I find now, because with 3D scanning and technology, with guided surgery, it helps, but sometimes it can also end up being a deterrent in the sense where you don't feel what you're drilling and you can't feel how good the bone is, and you have to decide at one point of drilling whether IIPP is possible. I always tell patients, I'm shooting for IIPP, but I'm not guaranteeing you 100% that you will get IIPP on that day of surgery, because my job is to do what is safest for you. And thus, if I see at any point during the surgery, after assessing all the factors, that this is not a scenario for IIPP, I will stop. And sorry, we have to wait and go back to type 3, type 4, type 2, doesn't matter. Any one of the implant placement scenarios is needed when we end up in that situation. So I do use guided, and a guided is necessary sometimes for the initial bit, and upon getting the initial engagement, I don't like to use the guided anymore, in actual fact, in my private practice. And as you saw in the video, the stent was being thrown out because I felt that it was not in the right angle. So yes, yes and no. But for surgeons who are starting out, please try to use a guided, because it helps you think through during the planning of the surgical stent, how or where are you going to engage the implant, and how or where are you going to ensure that the implants are going to avoid any other anatomical defects or pitfalls that can happen during surgery. Yeah. The next question, did you prefer always using the customized healing abutment in the anterior region? Yes, previously, if I only do that if I can't provisionalize, which means I can't put a temporary crown because the top value of the implant is so low after it's less than 35 Newton centimeters, and it's not safe to put a tooth on. Thus, we use we use a temporary abutment and customize the healing abutment to support the tissue and make sure that there is no contacts. And so that is one of the methods, and that's one of the fallbacks when IIPP is not possible and you end up with an IIP. Yeah. When should we do the crown when we don't have 35 torque? Well, when you don't have the 35 torque, the advice is to go to a customized healing abutment to ensure that the soft tissue is being supported, and that will be the way to go. I have throughout my years, I've pushed one of the envelope on one patient where I felt that it was good enough, and I placed the crown, and true enough, I lost that implant, and I'll forever remember that implant that I lost, because over the last 10-15 years, when we do IIPP, we are so strict with our protocol, we don't lose implants, and when you lose one, you feel the heartache at that time. Yeah, so that's why. When you have a high torque value for primary stability, what is the value you would think is too high for safety and it might cause failure? Well, too high is when you burn bone during drilling, or you necrotize bone when it's already 80, which is where the torque wrench is there to help you. If you're already at 80 and you're still trying to push it, then you're asking for trouble, because it's telling you I'm at my limits and I should not be pushed anymore. And if you pushed it, you are going to end up burning the bone, destroying the stability, and that's where you cause failure. And that may be one of the reasons why a lot of articles sometimes they end up with higher failure rates than what we see is because if the surgeon feels that he can continue to push or firstly he under-drilled, which means there was not enough drilling, and if you don't use a self-cutting implant, you're still trying to push it, then you're going to end up in trouble. Second is you are trying to push beyond what the implant is designed to do. That's when failure happens. So that's, I hope that answers your question. Yeah. And what type of bone graft do I use? Thank you. For many years, we were using xenographic. I'm not supposed to mention brands here, but will I get into trouble if I do? Well, we use BIOS for many years, but due to the studies that are being published, and these patients have come back for the last 10, 12 years, and we see no problems with them. In fact, when we took one of them, the longest standing one that we took a CBCT, we don't even see xenograft in there. We see patient's own bone that's completely grown onto the buccal bone area. And we don't have problems. And why we want a slow growing as well as a slow resolving type of bone is to ensure that the buccal bone is being supported all this time. Nowadays, we're switching more to allograft due to studies being published saying that xenograft may have problems, but we don't see it in IIPP, probably because it's in a small gap and it's surrounded by good own bone and good cells all the way around. And those are the two main types that we use. So allograft, cortical bone, small and big particles. Why? Because the gaps, it's hard to get into all the small corners, and you do need to use small instruments like the probe to really slowly pack the bone in to ensure that all the gaps are being filled. Yeah, I think I've lost track, and am I done? Thank you for, yep. Yeah. Okay. I think one of the last question, implant is now at 25 to 30 Newton centimeters. What would your next step be? Stage or proceed with provisionalization, pinpoint splinting with adjacent to? Good question. My answer was the customized healing abutment would be best. If you end up with if you end up with less than 20, please don't try to do a provisional crown at all right? Because you need to torque the temporary abutment to 15. And the last thing you want to do is when you're torquing the temporary abutment to 15, you end up torquing the implant at the same time. So that's not what you want it to be. Most of the time, we would actually use a customized temporary healing abutment to secure the tissue. And if, let's say, given now what we have with BLX, with all the different configurations of healing abutments, and I've seen some of them, they are actually very, it's customized in such a way that if your tooth is a lateral, you can almost just fit a simple healing abutment and you will get a perfect healing all around it. All right. If not, you have to customize the healing abutment. Then yes, you can pinpoint how you want to put a tooth on top of that, whether it's a denture or splinting. I don't have any preference for that. And obviously, splinting would be a better preference because with the denture, sometimes you can end up causing more recession if the denture is sitting onto the soft tissue. But most of the time when we issue a denture, for these patients, we actually have remove the contacts of the area that is touching the gums and as well as the implant. So we actually give a patient a fairly loose denture that is attached to the adjacent tooth but not attached to the implant area. Yeah, hope that answers that question. All right. Thank you so much, everyone. And I think that's it for today. And thank you again. We hope to see you soon, Monday. Bye.